to my YouTube channel. Karibu sana. This is me again, Jemienaftaly, on the pediatric world. This is the only channel that we discuss about the kids' welfare, the medical problems, and we also try to find solutions. So, welcome to this channel. If you have not subscribed, kindly hit on the subscribe button, subscribe. And if you are that returning subscriber, thank you so much for supporting me, and also I really appreciate. So welcome into today's episode, and in today's episode we are continuing with our topic on HIV in children. So today we are doing the HIV exposed infants. What do I mean with HIV exposed infants? Infants are kids, the small babies. These are a newborn that has been born. So if when we say HIV exposed infant, this is an infant that is born to a HIV positive mother. So we want to prevent this baby. Already they are exposed to getting HIV. If cautions are not taken, they are going to get the virus. So what do we do? What are the interventions that we do? We do interventions in various times. First of all, we do interventions during labor. This is a very important time, because this way, when the mother is in labor and they are HIV positive, the probability of infecting this unborn child is very, very high. So we take precautions during labor. What do? We make sure that we do not have something we call PROM. We mentioned this in our previous episode. PROM is a premature rupture of membrane. So we said this, that the membranes should premature rupture. The membranes should rupture spontaneously. I mean. So if we don't have PROM, then we are preventing this baby from getting infected. Another way is minimal use of invasive procedures during labor. And this we mentioned, things like neonatal sanctioning. You may find that you are needed to sanction the child. You need to sanction the child. So what you do, you make sure that we minimize or we avoid the invasive procedures. For example, the neonatal sanctioning or even episiotomies. Other way is we reduce the number of the VE, the vaginal examination. When you really want to know how many centimeters that this mother is dilated. So don't do so many VEs, because you're going to expose this child by doing those many VEs, the vaginal exams. Also, we try to avoid prolonged labor. The more the labor takes long, the more dangerous that this child, the unborn child, can get the virus. So also use of safe blood transfusions practices. So we make sure that this blood is screened in case this mother needs a blood transfusion. We ensure that it is screened and they are safe. So these are the interventions that we use. The interventions we do during labor to prevent mother-to-child transmission of HIV. So other interventions are done when now the infant is here, the baby has been born. So we do something we call infant prophylaxis. So we want to prevent. Prophylaxis basically means prevention. So before this baby gets this infection, we want to prevent. So we give the drugs, the ARV drugs. Yes, it is the ARV drugs that we use to prevent for prophylaxis against HIV. So the most commonly drugs used, I'm sure you have heard this. We have zidovudine, that is known as AZT. This is a zidovudine. The other drug we use in prophylaxis is nevirapine. So known as NVP. So these are the two drugs we want to use to the baby immediately, and these are given to babies immediately they are born, before 72 hours elapse. So before 72 hours elapse, this is when we want to give to initiate these two drugs at birth, and we give them for up to 6 weeks. Up to 6 weeks we give these two drugs, and this should be continued, the two. After 6 months now, we drop the zidovudine. This one we said it is called the zidovudine. The AZT we drop, and we are left with nevirapine. With nevirapine, we continue until 6 weeks after the mother ceases breastfeeding. When the mother stops breastfeeding, we continue with nevirapine for another 1 week after the mother has stopped breastfeeding. Hope this is clear. So we are saying that zidovudine is up to 6 weeks. The first 6 weeks you use the 2 drugs. Then after 6 weeks you drop the zidovudine and you're left with nevirapine. Nevirapine, you continue with it until 6 weeks after the completion, after complete cessation of breastfeeding. Hope this is very, very clear. When we are doing this, we also do a test by the name PCR. PCR is done to an infant that is to a baby born by a HIV infected mother. So we do the PCR the first 6 weeks when we are starting the when the baby still is on this prophylaxis, these ARV drugs. We do the PCR at 6 weeks. Then we repeat it at 12 weeks. I mean, we repeat it at 6 months. So what we do, if PCR is still negative as we repeat, so we do at 6 weeks, we repeat at 6 months, we do at 1 year, and now we do for 18 months. So every time we are doing the PCR, we are following up on the infant that to make sure that this baby still is not yet infected. So every time the PCR is negative, we wait for the next. If it's 6 weeks, we wait now for the 6 months. After 6 months, we wait for the 1 year. After 1 year, we wait now for the 18 months. 18 months, we don't do the PCR. We do something called antibody testing. So antibody testing, this time at 18 months is where now we are sure we can be able to tell if this baby is really HIV positive or HIV negative, depending. So at 18 months, the baby is negative. Now we stop with the test. We don't continue with our prophylaxis. Now, this baby is marked to be HIV negative. Now we give to the mother and we tell them how to feed them. If after 18 months, that is 1.5 years, the baby, the antibody test turns to be positive, this baby is known to be HIV positive. And here we initiate the treatment immediately. We start doing the treatment, and this confirms that the child is HIV positive. I hope this you can be able to understand all this. How about the WHO infant feeding guidelines? What does it tell us? How do we feed these babies? The babies born to a HIV mothers. What is recommended by the WHO, the World Health Organization? So the World Health Organization recommends that exclusive breastfeeding that should be recommended for all HIV infected women for the first 6 months. This one raises the question to many people that others say the child should not be breastfed, others the child should be breastfed. So what is there is that this baby should not be denied, just like any other baby who is HIV negative. The one we recommend every time, we say that the breast milk is the standard milk. So even the HIV, even the babies born by the HIV mother, we recommend that for the first 6 months, the baby is started on given the exclusive breast milk. That is giving just the breast milk alone without doing the mixed feeding. And this is the only alternative to breastfeeding is if other methods are AFAS. AFAS for capital A, F, A, double S. And A, we say, not unless first the alternative is affordable. If this mother is able to afford another alternative other than the breast milk, so we are saying we don't do mixed feeding. It's either the baby breastfeeds for the exclusive 6 months before we start on complementary food, other food, we don't mix. Or if we don't start breastfeeding, this baby should not breastfeed. But we are saying the WHO recommends that every baby, every child born by a HIV positive mother to be exclusively breastfed just like any other baby. You should not lose this. In our episode on breastfeeding, you can revisit and really see the importances of breastfeeding. So we are saying the only alternative to breastfeeding is if that method is AFAS. First, A is affordable. If the method they want to go for is affordable, doesn't have to cost them so much. If it is feasible meaning it is the time and knowledge. They have the knowledge on how to go about this other method. And the other A is for affordable again. Yes, affordable. Also sustainable. If this mother is able to give this alternative method, a continuous one, without like doing today and they're not doing it tomorrow, because we really need to feed these babies just like any other baby. So it should also be sustainable. The other S is for safe. The method should really be safe, that we are not contaminating anything, that these babies are getting safe feeding, that is if not breastfeeding. So then if it is AFAS, then recommend avoidance of the breastfeeding by HIV mothers. So if they opt to go for other alternative other than the breast milk, other than breastfeeding for the first 6 months, and this method, we are saying this alternative is AFAS, it is affordable, it is feasible, it is sustainable, it is safe, then you can recommend to use that. Again, they should not breastfeed. If it's breastfeeding, we just do breastfeeding for the first 6 months. If you're not breastfeeding, we don't reach a point and we really want to breastfeed. So this is it. Please explain to the mothers so that they can really understand. Also, now refer the child and the carers to on HIV support clinics. Refer them there. And another point is that all HIV exposed and infected infants should be started on septrin prophylaxis from the age of 6 weeks. From the age of 6 weeks, again, you want to give prophylaxis. Remember, we said prophylaxis is basically prevention. Why are we giving septrin when we are doing the ARV prophylaxis? It's because septrin will prevent us from having other infections, especially pneumonias. So we want to prevent this baby from getting, they are called opportunistic infections. So that is why we are giving septrin. So now we have something we call infant comprehensive care package. Infant comprehensive care package. What does it involve? It involves what we've just said, the septrin prophylaxis, prevention of other infections like pneumonias. We also do micronutrients. We also do supplements. We give these babies supplements. Here we also do staging and evaluation for the ARV initiation if the child is positive. And we said it's at 18 months when we do the antibody testing, which is the confirmatory test. And we find that after 18 months, the antibody test tells us that this baby is HIV positive. So we don't waste time. We initiate these babies. We initiate these babies as early as possible on full HIV treatment. That is the ARV regimen. So in comprehensive care package for infant, we have the staging and also the evaluation for ARV initiation. So this is it, my people. I hope now you understand. I'm trying to make you understand how instill ways of prevention, mother to child transmission of HIV infection. We want to prevent these young ones. We don't want to get infected, and it is very, very possible if we take precautions of what we are saying. We are saying during labor, prophylaxis after birth, and also now when it comes to feeding, no mixed feeding, and we advise the mothers accordingly. Thank you so much, my people. If you have any question regarding the HIV infection, regarding today's episode, please ask in the comment section. Any clarification, you can still ask. Also, my email is provided in the end of every video. Please ask questions there. Thank you for those coming. I appreciate so much. Thank you. This is the end of today's video. Till next time.